following, like uncontrolled symptoms, moderate to severe distress-related cancer diagnosis and therapy, and serious comorbid physical and psychosocial conditions, complex psychosocial needs, poor prognosis, potentially life-limiting disease, metastatic solid tumors, patient or family or caregiver concerns about course of the disease and decision making. Our patient family caregiver gives request for palliative care. Our patient request for a hasten death. So all of these give some form of indication that when we should start palliative care, but actually in oncology, what happens is it is the treating doctors who decides when to start these patients on palliative care. Very few times the patients actually ask for to start palliative care, because most of the times what happens, the patient doesn't have proper knowledge about the palliative care, what it is and how it goes, and even the non-oncology doctors, many of the non-oncology physicians doesn't know the exact details about this palliative care. So the guidelines are there, but very few know actual time to start palliative care. So what are the indicators of short life expectancy? Is the poor performance status and the presence of hypercalcemia or brain metastasis or CNS symptoms, or cachexia, spinal cord compression, malignant effusions, or palliative stenting. All these are indicators for short life expectancy. So you see that these are criteria for consultation in palliative with palliative care specialists. So these are all given in the slide, so you can read it. Whatever I was telling so far are listed here in a single slide. So what we do when we select a patient for palliative care, we will assess the patient. So we will assess for the benefit. So what type of therapy should be given in palliative care and how it affects the patients, what are the outcomes, what are the benefits, what are the burdens and the patient, or what are the burdens and the family, like what is the cost, like economic burden and the physical burden, this psychological burden. All those things we have to assess before starting any form of palliative therapy. And we should also assess the patient for any symptoms and the ways to alleviate these symptoms. Like the patient is having pain, and we should assess the pain severity and pain grading. Then we should treat the particular symptom like the pain with the painkillers or the analgesics. And the patient is having psychological problems, like the patient is having stress related symptoms or anxiety related symptoms, then we should address those symptoms separately. So, and we should also at the same time educate these patients about their disease course, and we should also educate about the need to be clean and need to be healthy, need to take healthy diet. So the assessment will be in different forms in the clinic, like we should assess the symptoms, and we should assess the severity of the pain. We should assess the social and spiritual condition of the patient and the nature of the illness and prognosis of the disease. And then we will set some patient-centric goals, and then we proceed with the palliative care. And it's a never-ending process. The palliative care, it only ends up, it will not even end with the death of the patient. It will continue after the death of the patient also. That is called bereavement. So that we'll discuss later. So as part of palliative care in advanced care, advanced stage of the disease, so first we will assess is there any therapy that is suitable for this patient. Then if some therapy is there, then we will assess what are the benefits and what are the side effects of this therapy. Then we will explain these things to the patient and patient's family. Then they will decide whether to go for the therapy or whether to go for supportive care. So these are all part of palliative care management. So it is always a shared decision. The palliative care is always a shared decision, and it involves patients, family, and the caregivers. So it indeed need advanced care planning, and the goal and meaning of that. And it includes anti-cancer treatment, and the center of the goals is quality of life. So as I said, in palliative care, usually and most part of it, we manage the symptoms that the patient is having. The cancer patients at the end of their disease, they will have multiple symptoms based on the location of the tumor. The most common symptom is pain, and the patient is having some lung disease, they will have this dyspnea, shortness of breath, and other common chronic illness symptoms like anorexia, cachexia, nausea, constipation, diarrhea, malignant bowel obstruction, fatigue, insomnia, delirium. So all these symptoms may or may not happen. So depending on the symptom, we treat the patient with appropriate medicines. Then patients, because of the disease status, because of the disease severity, can have multiple psychosocial symptoms like depression, anxiety, stress. So all these things should be addressed separately. So the treating physicians will counsel the patients in their own way, and if it is not possible to treat these psychosocial symptoms from the physician point of view, then they will be referred to either psychiatrist or to the cancer psychology team that is specially situated in most of the cancer centers. So those the psychology team will talk to these patients, and they counsel the patients in their own way to alleviate these symptoms. And sometimes, if requires, they will be referred to psychiatrists for the medical management of the symptoms. So if you see the aspects of palliative care, you will have physical, psychological, psychiatric, social, spiritual, cultural, ethical, and legal. So there are multiple aspects. It's a multifaceted therapy. So when the patient is in palliative care, as I said, education is very important. We should educate the patient, educate the family. So what is hospice? Hospice it is defined as the care that is designed to give supportive care. So hospice is different from palliative care. So hospice is care, it is a form of supportive care. The people in the final phase of terminal illness and focus on comfort and quality of life rather than cure. But in palliative care, we do try to get some disease in control, but that is not the palliative care. Quality of life is the main thing there. But at the same time, we do offer some therapeutic options. So as I said, palliative care doesn't end with the patient's death. Even after death, we do counsel the patient's family for any psychological burden that is called bereavement care. So if you see the palliative care and hospice care development in India, it is slowly picking up the pace. So there are more than 150 centers in over 16 states that are available as of now. It is widely spread in Kerala, and in other states it is modest to low actually. Even in other states, the majority of the palliative care settings, they're only in the medical college or the apex centers. But in most of the private institutions, in the small hospitals, the concept of palliative care is not that prevalent because it involves multiple people. It involves multiple departments. Like if I can mention the departments, palliative care includes pain clinic, it includes psychology clinic, it includes occupational therapy clinic, it includes physiotherapy clinic, it includes oncology team, oncosurgeons, radiation and surgical oncologists, and it includes palliative care physician. So there's so many people involved in palliative care. So it is practically not possible that every small center to have these facilities in their place. And there are multiple barriers also in India. So it is it's a motto, and it is the what do you call it's a duty of the government and the people of our country to make it affordable, sustainable, and available to all the people in the country. So in patients in the palliative care, when we don't have any effective treatment options in our what do you call it, the form of chemotherapy, surgery, or radiation, then we suggest those patients to go for any alternate therapies if they are willing, or if they have any belief in alternative therapies. So we have different forms of alternative therapies. So patients can take any these alternative treatment options as part of the palliative care. So as I said, we do manage symptoms. So here, one example is given here. So pain, if we have pain, then what we do? We first assess the pain severity with multiple pain assessment scales. So based on the score, then we treat the pain with analytics based on the WHO pain ladder. So here you see we slowly increase the amount of drugs and the quality of drugs to with respect to the pain severity. So initially we start with NSAIDs and analgesics, and then we start with weak opioids, then we go to strong opioids. Then if it is not elevating with these medicines, then we go for nerve blocks or epidurals. So when the palliative care is over, if there are no options, then the patient is offered end of life care. Here the patient will not be offered any form of therapy or any form of the treatment options. Here the patient is kept peaceful with the help of any pain medication, and patients are left to die on their own. So this is the take-home message. So palliative care is part of cancer therapy, and it should be started as early as possible. That the treating physician, along with caregivers, patient, and his family, should work as a team in palliative care. And in India, it is still developing. So all patients of cancer should be given good quality of life till the end of life, and hospice and bereavement should be part of your palliation. Counseling the patient and his family about the disease, the options of the treatment, and prognosis should be done for better decision making. And patient autonomy, willingness, and preferences should be respected. Emotional, spiritual, psychological support to be provided to the patient and his family. Finally, the patient should have pain-free life till the last breath and a peaceful death. Thank you.